How are you, folks? Nice to meet you. So my name is Derek, as you've heard, and I'm delighted to speak to you today at this excellent forum that's been organised about how we map out where we're going with healthcare in the next 5 to 10 years. So the Digital Health Project. So the first thing about this that we're doing in Galway, just to give you that perspective, that I am a physicianeer. So I trained as an engineer originally, did a degree, master's and doctorate in electronic, computer and biomedical engineering. And then did medicine, so did a degree, master's and doctorate in medicine. And so when I got my permanent job in 2018, my father cried. He was so happy I was finished college. He was like, kid, you made it. But the reason I tell you that is because engineers are solutions-orientated, problem-solving, very black and white in the way they look at things. And anyone who's a clinician here knows that nothing's ever black and white, and it's full of problems. And everything is a spectrum of colour. So it's a nice mix of skills, I would say, for innovation. And I think that's important when you're talking about digital health, because you're disrupting the way we do medicine. And medicine, by its nature, is a conservative, part of our society. The central tenet of medicine is primum non nocere, which is firstly, do not harm. So whatever you do as a clinician, don't make it worse. And therefore, we're kind of reticent to try very new things that haven't been extensively sandboxed and tested. So I work in Galway. It's a beautiful part of the world, obviously, the west coast of Ireland, with a clinical team. I also am the national clinical lead for diabetes. Look at these happy people working in the HSE, because one of them has just realised that today is the World Diabetes Day. So today is November the 14th. Today is World Diabetes Day. And I was watching what you're eating outside with the scones and the tea. So just a time to reflect on the tsunami of chronic disease that we have in general, but particular diabetes, where the Lancet calls it the defining disease of the 21st century, and that's post-COVID. So just to think about that, 1.4 billion people will have diabetes by 2050, 1 in 10 people. And then my other job is I'm the PI, as you heard, of the Hive Laboratory. So when I started in 2019 in Galway as a consultant, I was appointed also as Professor of Medical Technology, and I was diagnosed with a fatal disease called new consultantitis. Where unfortunately you think you can change everything because you have all these great ideas. Why is that broken? I'll just go in and fix it. But then obviously you realise pretty quickly that you're swimming in treacle. But that shouldn't stop you fixing things, okay? Especially things that are in your scope of control. And then collaborating, which is a big theme of my talk today. So just like a honeybee can't make honey on its own, it needs a hive. So we set up the hive. So we'd work collaboratively with psychologists, computer scientists, engineers, and so on. And we've done very interesting projects over the last 5 years. From robotics to avatars to AI to clinical practice. And it's all been done through collaboration. And that's the first thing to say. Nothing gets done with an idea in your head. You need to share it and you need to build. And so in those 5 years, we've done a lot of things, from funding and publications and patents. But one of the things I'm most proud about is we got an exhibit featured in the Museum of Science in London, where I walked around as a kid looking at all this cool STEM stuff. So it's nice to think about STEM. But back to our day job, we are all very, very busy at work. That's just the nature of being a clinician. You go in and it's just busy. The demand is more than the resources often. But even still, we need to step back now and then and say, why are people keep falling into the river? Eventually we've got to go upstream and figure out why they're falling in, not just pull them out of the river downstream. So we need to actually figure out, why is the hospital busy? Why are the EDs overflowing? And when you think about that, you think about digital health solutions as a possible option. I remember a few years ago when I was post-call one day, and we went down to the ED, and there was just bedlam, there was trolleys everywhere, and we couldn't really get past because it was so busy. And one of the clinicians with me was like, this is crazy. And I was like, yeah, there's so many people. How are we supposed to work like this? And they said they should really just develop like narrower trolleys so we can get around. And I was like, yeah, that wouldn't have been the solution I would have reached for. But it reminded me of that phrase from Henry Ford, the car manufacturer, who famously said if he asked people what they wanted, they would have said faster horses. So you do need sometimes to think differently and think of other solutions. And digital health, as we've heard this morning, has a lot of opportunity to improve care, especially when you look around the ED of actually what's in the ED. So when you think about the presentation of different diseases, and in particular the healthcare spectrum that we have from birth to death and from the different types of diseases, from acute to chronic, You see this triangle a lot, and it's a really important way of a framework of looking at it. You have preventative care at the bottom of the triangle, so we do a lot of projects in that area about keeping people well and healthier longer. We have proactive care, which is trying to keep people healthy and keep them out of hospital, which is what I'm going to talk to you about, admission avoidance. And then the other part, which is very important, which is acute care, which is what we think about typically when we think about healthcare, even though, as we heard, general practice is probably the main source of healthcare interaction in the world, and talking about data earlier, if we could analyze some of the data out of GP practices, that would be phenomenal. We'd see diseases quicker than we would before they come into the ED and so on, and have a dynamic system that could respond to it. So acute care, obviously, so with Colm Henry and Deirdre McNamara, Richard Green, Loretta Grogan, we launched the virtual wards earlier this year in July in St. Vincent's and in Limerick, and hopefully more of them around the country. That's to take patients who are in hospital and to discharge them safely home earlier. That time, for example, when you go from an IV antibiotic or an IV diuretic to a PO, so an oral equivalent, that's a great opportunity to get people home safely, because, as I say to the medical students, the most expensive hotel in town is the hospital. Right, so it's $1,000 a night. And that's both expensive for the HSE, but also for the patients themselves. So I've been involved with some of the committees to roll out the virtual ward, but also with the proactive care, which is what I want to speak to you about today. And that's about the Clare Island project. So back in 2019 BC, before COVID, I proposed that we did this project in Clare Island, that we would look at a remote community and see how we could manage their chronic disease. Why is someone getting a ferry 2 miles from their island to the mainland, driving 2 hours, parking for an hour, sitting in a waiting room for an hour to talk to me for 10 minutes? It just makes no sense, right? And especially if it's a chronic disease, because chronic disease needs lots of adjustments, be that heart failure, COPD, or diabetes. So we chose Clare Island because it's a great microcosm of life. There's about 160 people on it. It's representative of what Ireland will look like in the next couple of years, because it has a significant aging population. And it's quite remote. So when I first went out there, I couldn't get a cell phone signal. And I remember thinking, yeah, that's perfect. That's actually the sign that I want, because if we can actually make this a hub of digital health, then we can do it anywhere. So we're actually going to call it Project New York, because if we could make it there, we'd make it anywhere. But that was too confusing. So Clare Island is an island off County Mayo, and it's been a fantastic sandbox to test out lots of different ideas, both the technical and also the clinical, because that's really important as well. Very easy to have or take off-the-shelf technical solutions and adopt them. Very difficult, as I mentioned earlier, to change the mindset of clinicians who are used to doing something a certain way because it's been proven, flight tested, and it's safe. And so part of the process of digital health change, as mentioned earlier by Damien, is that idea of clinical leadership and clinical engagement. That's a super important part of trying to make this operational, as opposed to the disease that it suffered from for 20 years, which is pilotitis. People doing lots of pilot studies and getting a paper, and then that was it. So we've been very cognizant of trying to work with and integrate and collaborate with the national policies in this area, and it's great to see such action in this. We've hit the crest of the wave at the right time with the European rules that are coming in the next 5 years, as you've seen earlier. So we looked at virtual consults, we looked at remote monitoring of patients, we looked at health promotion. So what that looks like is a patient, for example, who has a diabetes appointment. I can see them on the screen, but then on the other screen, I can see all their blood sugars, all their insulin, all their step count, and all their quality of life feedback. So I can say, hey, Frank, I see on Tuesday mornings you're going a bit low. Do you feel that? And he goes, yeah, I feel a bit woozy when I go out in the fields. And I say, all right, so what's going on Tuesday mornings? And he said, well, it's actually the last 2 weeks. It's a kind of spring season for the lambs. And yeah, I'm just more active. And you go, okay, well, maybe you could dial back your insulin on Tuesday mornings for breakfast. So you can have very rich conversations with people just like they were sitting beside you, and far more efficiently. And I think that's going to be a big part of chronic disease management going forward. So once we had tested lots of different things, and obviously being a university, we're kind of an ideas factory. So we tested other interesting things with robotic dogs, like St. Bernard dogs, and AI triage. So if you think about it, with all this data I was getting back from Clare Island, and I could see people's blood sugar, blood pressure, and all the different indices, you could think about an example whereby last week when I was at my diabetes clinic and I had 50 patients at my clinic, maybe 20 of them were what's called one-year follow-ups, just an annual follow-up. So of those 50, 20 were there because it was a one-year follow-up. Of those 20, how many needed adjustment really? And the answer was probably, maybe 5. So 15 people turned up just for me to say, how's it going? Everything's going grand. Numbers look great. what's going on in the US election, and then safe home to you. And that's it. So you can think about, we kind of over-medicalize people who didn't need to be seen because everything was going well. So in the future, when you have this digital connectivity, and as we talked about secondary availability of data, we'll be able to monitor the data streams, and we'll be able to dynamically triage people into appointments. So if I see somebody at clinic, no matter where you get your medicine in the world, in Oxford or in Boston at MGH, the clinician sees the patient, has a history of, okay, I know that they've been well for the last 6 months. They've told me what they're like today. I'm going to bring them back in 6 months or 12 months or 3 months. They make a clinical decision. But now with the technology, we're able to dynamically triage people back sooner if something happens then when they leave our clinic. So for example, if they go out and they get diagnosed with breast cancer and they're on dexamethasone and so on. So following on from the Clare Island project, we have the Healthy Islands project. So that's allowed us to expand what we've done on Clare Island to 3 other projects. This is a Sláintecare funded project. And these islands all have a nurse 24/7 there, but the GP only visits them maybe 1 or 2 days a month. So if it's stormy that day, they don't get their GP visit, and that's a problem, especially when the storms happen for many months here in Ireland. So we've expanded it, and we've put in telehealth solutions to allow a full suite of vitals to be done remotely that the GP can access and that the patient can use if it is an acute issue, or indeed for outpatient monitoring. And so that's really important, and it's an interesting project that we're doing with Sláintecare. And that builds on to the other elephant in the room, as I mentioned, which is the hospital. So again, we think of the hospital when we think about medicine. But one of the challenges is that the hospital isn't really built for chronic disease management. It's built for heart attacks, for pulmonary embolisms. It's not really meant for people with chronic disease that deteriorate. And we know that because it's overflowing, because it's full of people who have chronic diseases and deteriorate. And we do have a bed crisis. We know that, unfortunately. We've all had siblings or parents or our own families who've been in hospital on trolleys, and I mentioned the example earlier. And so the idea is, could we build a virtual hospital? We're not great at building capital projects in Ireland, so I figured I could build a virtual hospital. And so what that meant is we essentially gave people kits, as you see here. This is Dr. Sinead Walsh. She leads our respiratory admission avoidance pathway in Galway. She works in the community hub. And the idea is, if there's patients who have COPD and they start to deteriorate and they go to their GP, rather than sending them into the ED, they can send them into the virtual ward. And then they can be monitored by Sinead and her team and kept out of hospital, kept well. And there's several patients now who usually come into hospital at least 1 or 2 weeks a month, haven't been in hospital in 4 or 5 months because of that. So that's a new way of doing it. And as well as that, since we started in April, we've saved roughly about 340 days, 350 days, I was told this morning, in bed days. Physical bed days saved because we could have people in these virtual beds at home being monitored safely, of course. And the next project where we started was looking at cardiology. So in cardiology, this is Dr. Naria Farre, so we're doing heart failure. So about 1/3 of all people who get discharged with heart failure come back in again. So what we're looking to do there is to prevent them coming back in again by monitoring them at home. And often what you find is someone's weight is going up, for example, in heart failure as a surrogate for deterioration, and you contact the patient, and we have it RAG rated, red, amber, green. So if it goes amber, you can ring the patient and say, what's going on? And they say, well, I'm out of my diuretics, but I can't get into my GP till next week. And so that patient traditionally would have just deteriorated and crashed into the ED. Whereas now we're spotting it earlier and intervening and keeping them out. So we've started respiratory, we're doing cardiology, and we're also looking, this is Dr. Susan Connolly, our lead for arrhythmia. So again, a lot of admissions during the year because people have palpitations because they drank too much coffee and with their scones. And the question is it pathological or not? And you often have to stay in hospital for a while as they figure that out. Now we're working with Patient Empower, who are here today, and FibriCheck to use your smartphone, that you can put your finger over the lighting camera on your phone, and it'll actually tell you if it's regular or irregular rhythm, and then we can grade you and treat you appropriately virtually and through the hub, again, keeping you out of the hospital ED. So I'll finish on that just by saying these virtual hospital is up and running in Galway with these admission avoidance pathways. We have about 330 bed days saved so far, and I said we started the heart failure and arrhythmias with diabetes up next. We're also looking at the outpatient department because the hospital isn't just wards, it's the outpatients, it's the pre-hospital care and so on. And it makes sense, right? So it saves hospitalization, the disruption in the patient's life. It saves money because you're not using beds. It reduces the crush in the ED because the population is getting bigger and is getting older. And then obviously you're not traveling as much to the hospital, which is good for the environment for outpatients. And this guy here, Chris O'Grady, just to say it, He doesn't mind me mentioning his name because he was on Nationwide earlier this year on a program that we featured on. And actually, interestingly, I got invited to the White House to Joe Biden's PCAS, President's Council of Advisors in Science and Technology, to talk about AI in healthcare earlier this year. And I told my dad, and my dad was like, "No, that sounds good. It's not the Dáil, but okay." But actually, Chris was on the Nationwide program. He lives on Clare Island, and he's had virtual care now for 2 years, and was featured on Nationwide. And when Nationwide was over, my dad rang me and said, "You made it, kid. You're on Nationwide." It's like, grand. But just to tell you about Chris is 94. He lives on Clare Island. He told me that when he first was born on Clare Island and was 7 or 8 years of age, the way they communicated with the island, or with the mainland rather, if they wanted a boat, was they used to light hay and then wave it in the sky, so smoke signals. And then 10 years later, they got radio, and 10 years later, they got TV, and then eventually they got a phone, and eventually they got cellular phone, and now they have internet, and now they have 5G because of our project. So in one lifetime, we've done a lot. So just to finish on one last thing is that tonight on RTE1, they have a series this week, you're probably watching it, called Welcome to Futureville, 7 to 8 every night. And tonight, good timing, we're actually being featured our admission avoidance pathway with Emma Burke, our AMP, and Sinead Walsh. They'll be telling you more about how it works in reality, but also the impact on the patients' lives. So thanks very much.